والفين أصلا.
Yes, he told me that he will be late a little bit too.
Yeah. Okay.
Okay. So I want to hear what you think about some of the new trials that were discussed in the last ESMO. Start screen sharing. So in the last ESMO, they discussed the results of the Destiny Breast 11. Next slide. Oh, so now TDX is not only in the advanced setting, it's now in the near future, we'll see it in the neoadjuvant setting as well. So this trial had 3 arms, and arm who received just TDX for 8 cycles as neoadjuvant. Arm 2 received the 4 cycles TDX followed by 4 cycles of Taxol, Herceptin, Perjeta, and the third arm was a standard arm. I was interested to know what to do after receiving neoadjuvant TDX. So in the trial design, if the case achieved PCR on neoadjuvant TDX containing regimen, it would continue Herceptin Perjeta in the adjuvant setting. If no PCR obtained, it would continue TDM1, not TDX, okay? And in the TDX alone arm, if the patient didn't achieve PCR after 8 cycles TDX, it would be considered to receive the standard chemotherapy 4 cycles anthracycline followed by 4 cycles taxane plus combined anti-HER2 blockade, okay? And in the at certain point of the trial, they just stopped enrolling patients in the TDX alone arm because there was the low PCR rate. Next slide. So this trial included advanced cases. About half of the patients were T3 and T4, and 88% of the patients were node positive. As you can imagine, the TDX THB arm had the highest PCR rate. It was 67.3% versus 56% in the standard chemotherapy arm versus 43% in the TDX alone arm. Also, a favorable trend in event-free survival was emerged with the taxane TDX arm with 96.9% versus 93.1% of the chemotherapy and the standard of care that we use now. About 3.7% improvement at the event-free survival at 24 months. And the TDX regimens were less toxic than the standard. Okay, next slide, please. We have also the Destiny Breast 05, which compared patients who received the neoadjuvant dual blockade and didn't achieve PCR were randomized either to receive TDX for 14 cycles or to receive TDM1 for 14 cycles. Next slide. So treatment with TDX showed about 9% absolute improvement in the 3-year invasive disease-free survival over TDM1, and the p-value was significant. Also, fewer CNS metastases were observed in the TDX arm. Okay, so this raises a question. I want to hear what you think. Would you encourage patients to receive TDX in the early setting? Knowing that we don't have a better drug to give to the patient upon progression? Yes, some oncologists may be optimistic and want to give the strongest drug, hoping for like achieving complete response, and the patient may not need to receive any treatment. But the other pessimistic oncologists may say that we need to have some plan B if the patient was resistant or not achieving the desired response to such a strong drug. So what do you think? Dr. Luay, would you suggest giving TDX in this early setting or wait till we have like plan B?
Well, for patients with we should note first that the Destiny Breast 05 included patients that are generally higher risk than those who were included in the Catherine study. So this is very important to note. So those patients are more likely to relapse compared to those patients included in the Catherine study. So if I have a typical patient of this DESTINY-Breast05 study, which this means with a high rate of expected rate of recurrence, I would prefer to give a treatment that would prevent the recurrence rather than think about the sequencing, because let's be clear that we are talking about sequencing therapies in patients with metastatic breast cancer that are HER2 positive and that are relapsed after receiving T-DM1. So typically those are poor prognosis patients. And while we have TDXD in the first line and second line metastatic and third line metastatic settings, we do not have any radical treatment for them. So you would sequence some palliative therapies, which well, they did improve overall survival, but again, for the long term, we do not have any hope of curing that disease till now. So to me, if I have a patient with a high risk features, like the majority of patients in the DESTINY-Breast05, I would prefer to use to prevent recurrence rather than to have recurrence and have some additional weapons to use against that recurrence.
Okay, but if you have like an unlucky patient who developed the progression after TDX, what can you do now if this happens? Would you give TDM following progression on TDX?
I would do the same thing that I would do to the metastatic patients, because again, if we will use TDXD in the relapsed patients, we should have again that will not be for life. The majority of the patients who start TDXD in the metastatic setting, they will have to stop it, mostly because of progression in the majority of patients, and in some patients because of intolerance. But we will have to stop it and think what to do after it. That's the inevitable situation that we will face in every patient with metastatic disease. So again, if I will have TDXD to use in the metastatic setting, then I should also know what to use after TDXD, because that situation will happen in the majority of patients. To me, I would do the same like that I will do in TDXD following recurrence, especially in patients who do recurrence after have recurrence after a long time after receiving TDXD. For example, if the patient finished the treatment in like 9 months from now, and she did relapse after 5 years, I would have the option to use TDXD again. That's an option, and by that time, most probably we'll have another options to use. So that question is most difficult to be answered right now, rather than in 5 years, for example.
Yes. Okay. Next slide, please. Okay, we will talk about a little bit about antibody drug conjugate again. So now for triple negative patients, it's not just pembro in the neoadjuvant setting. We have now ASCEND-03 trial that compare the sacituzumab versus chemotherapy in patients who are ineligible for IO. So giving sacituzumab can improve the median progression-free survival. It was 9.7 months versus 6.9 months. The overall response rate was similar. Like 2% difference was not statistically significant, but the median duration of response was longer with the SACI arm, 12.2 months versus 7.2 months. Also, next slide, please. We have the TROPION-Breast02 also for triple negative patients who are ineligible for IO. The median PFS was longer with the DATU-DXD. It was 10.8 months versus 5.6 months. And overall survival also was statistically significantly longer, 23.7 months compared to 18.7 months. And this trial included the patients with more aggressive disease than the ASCEND-03 trial. Next slide. Okay, so we all know that cross-trial comparison is not a healthy thing to do, but we just tend to do it anyway. So it seems that TROPION-Breast02, the TROI is just it seems like better than Trodelvy. Okay, in terms of overall survival benefit, PFS, overall response rate, and also lower toxicity incidence. Next slide, please. Also they discussed in the last ESMO the patient-reported outcomes of the ASCEND-04 Keynote D19 trial. This trial that compared sacituzumab plus pembrolizumab versus chemotherapy plus pembrolizumab. Okay, in the previously untreated, locally advanced, unresectable, or metastatic triple-negative breast cancer. In patient with the BDL1 more than 10, CBS by CBS score, and more than 6 months since treatment in a curative setting. So not primary resistant diseases, I mean. Just the patient-reported outcome favored the combination sacituzumab pembro arm. Okay, Dr. Luay and all the attendees, do you have anything to discuss or to share about these trials?
Well, I can jump in again.
Yes.
Regarding the question of the hour, if we can say it, the comparison between the ASCENT-03 and the TROP, so the patients with triple negative breast cancer who are not eligible for pembrolizumab, which are the majority of the patients actually with metastatic triple negative breast cancer for the first line. So I think for two reasons, I might consider giving the Day-to-DXD rather than the sacituzumab. The first would be that the toxicity profile, while a little bit tricky with the ocular symptoms, but it's relatively less than what we expect from the sacituzumab with the chemotherapy like symptoms, because patients would also like to avoid the typical symptoms of chemotherapy, which are more likely to happen with sacituzumab. Again, we have we have no experience with using it right now because we don't have access to it in Egypt for both agents actually, for sacituzumab and for the D2DXD. The second is the overall survival. While again, it's not the final overall survival for both agents, yet the early overall survival generally in an aggressive disease is more intriguing to use it as early as we can. So to answer your question for the cross trial comparison, I would be more inclined to use the drug the Day-to earlier than the use of sacituzumab in the first line setting. That's to me. I'm not sure about how our other panelists would think about it.
Yes, I totally agree with you. Okay, thank you so much, Dr. Alfie. Can you please share your presentation now?
Okay, let's start.
Please unshare your screen, Dr. Mustafa.
The same.
مش مشكلة، احنا شايفين.
لا. This is okay?
Yeah.
Okay. Just 1 minute. Good evening, everyone. I will be presenting a case of high-risk recurrent triple-negative breast cancer with acquired HER2-low status. My voice is good, right?
Yes, everything is good.
Okay. So our patient, Miss Aisha, 38 years old, diagnosis in January 2023. She was premenopausal, ECOG 0, with strong family history, maternal aunt with breast cancer at age 45, and paternal grandmother with ovarian cancer at age of 60. Germline testing confirming BRCA1 mutation. She first noticed a lump in her right breast on self-examination. Clinical exam showed a 4 centimeter mass at 2 o'clock position and a palpable firm axial lymph node. Mammogram and ultrasound confirmed 4.2 centimeter Barrett's 4 lesion with suspicious axial lymph node. A staging PET scan show primary tumor axial lymph node with no distant metastasis. Biopsy showed invasive ductal carcinoma grade 3, AR, BR were negative, HER2 initially score 0, PDL1 was 20. Overall, she was staged as T2, N1, M0. Clinically, stage 2B, triple negative breast cancer. So we are dealing with a high risk, not positive, PDL1 positive, TNBC in a young BRCA1 carrier. She started neoadjuvant chemoimmunotherapy, Berkay-Note 522 in February 2023. We initially started dose dense AC, followed by weekly paclitaxel and carboplatin. Carboplatin AUC 1.5 and paclitaxel 80 mg per meter square, both concurrent with pembrolizumab. In August 2023, she underwent bilateral skin sparing mastectomy with axial lymph node dissection, including prophylactic contralateral mastectomy due to BRCA mutation. Pathology saw residual invasive carcinoma measuring 1.8 centimeter and 2 out of 14 axial lymph node positive. So she didn't achieve pathological complete response and remained in a high risk group for recurrence. Given the residual disease and the BRCA1 mutation, she continued the adjuvant pembrolizumab to complete 1 year as per Keynote 522. She also started adjuvant olaparib 1 year following the Olympia trial criteria for germline BRCA1 mutation, high-risk patient with residual disease. Capecitabine was discussed, but ultimately deferred in favor of olaparib given the strength of Olympia trial. Unfortunately, about 18 months from initial diagnosis, in March 2025, she developed persistent cough and mild dyspnea. The PET scan showed multiple new pulmonary nodules and FDG avid mediastinal lymph node, but no bone or liver metastasis. Her ECOG performance status remained 1. A lung nodule biopsy confirmed metastatic triple negative breast cancer. HER2 has converted from 0 to +1. So she is now HER2-low. AR-BR remained negative. PDL1 was 15 and the ECOG still 1. So at relapse, we have metastatic BRCA1 mutation, PDL1 positive, HER2 negative, TNBC. She is now 40 years old with metastatic BRCA1 mutated, PDL1 positive, HER2 low TNBC. She already received platinum-based chemotherapy, pembrolizumab, and PARP inhibitor in the curative intent setting. So the question now, what is the optimal first-line systemic therapy in this context? Let's move on to the question. Option A, sacituzumab govitecan, supported by the ASCENT trial. The ASCENT showed significant overall survival benefit versus standard single agent chemotherapy. It is strong TNBC specific guideline endorsed standard of care, including patient previously exposed to platinum and chemotherapy. Option B, trastuzumab deruxtecan based on Destiny Breast 04, which established TDX as the standard of care for HER2-low metastatic breast cancer, regardless of hormone receptor status. The key question is whether HER2-low conversion should push us to prioritize TDX over SCG at first line. Option C, re-challenge with chemoimmunotherapy. For example, gemcitabine with carboplatin plus pembro. However, given her relatively early relapse after adjuvant pembro, the expected benefit from the challenge is very low. Central issue is sequencing ADC. Should we start with sacituzumab govitecan, which has robust TNBC specific evidence, and keep TDX for later, or should we lead with TDX because HER2-low is now a clear actionable target? We can also ask whether TROP2 expression levels or intensity of HER2-low staining can help us individualize this sequencing. Given her aggressive BRCA1 mutated TNBC with visceral relapse, she is at very high risk for CNS involvement. One question is whether we should obtain a baseline MRI brain now, even in the absence of symptom. Another is which ADC, sacituzumab govitecan or trastuzumab deruxtecan, has a strong intracranial activity based on available data, and how that should influence our first choice if brain metastasis develop. So to summarize the evidence backbone, Keynote 522 established new adjuvant chemoimmunotherapy for high-risk early TNBC. Olympia supported the adjuvant olaparib for germline BRCA mutant patient with residual disease. Ascend positioned sacituzumab govitecan as a standard of care in pre-treated metastatic TNBC. Destiny Breast 04 created the HER2-low treatment paradigm with trastuzumab deruxtecan. Our challenge is how to integrate all of this for one real patient. Thank you. So for question, let's go back. Which first line would we choose? Sacituzumab or trastuzumab deruxtecan? Dr. Amanar, Dr. Lai?
Well, I think I would go for TDX. Because I think it has better CNS penetration if you are worried about developing CNS metastasis. Also, we have strong data for it on multiple trials. What do you have to say, Dr. Loai?
Well, I didn't get it clearly. When exactly did she relapse from finishing like olaparib or from finishing the
After
adjuvant
18 months.
18 months from the last olaparib, right?
Right. The initial diagnosis.
Oh, if it's 18 months from the initial diagnosis, then this is probably
1 year.
during adjuvant olaparib.
لا let's say 18 months from the end of olaparib, adjuvant therapy, all of her adjuvant therapy.
Yeah, if 18 months from the end of the adjuvant therapy, she's well, she probably isn't in the TDXD study, isn't in the Destiny Breast 04
Right.
typical patient, and isn't in the Ascent typical patient. I'm sorry, yes, she's not in the Ascent, she's not in the Destiny Breast in the Destiny Breast 04. So both studies were for patients who did receive 2 prior lines of therapy for the metastatic disease. So relapsing 18 months after that, she probably not fit. So she is within the Ascent 03 or 04 if you would re-challenge with the pembro. In addition, she received the adjuvant.
Yes.
Yes, I'm not sure. I'm not sure if actually if the consistent improvement of the ADCs in the first line is dependent or not on the addition of pembro. So now we know that the cystostomab plus pembro is better than chemo plus pembro. We're not sure if cystostomab plus pembro is better than cystostomab alone, and we'll not know that very early. But consistently in the patients who are not candidates for pembro, so the ADCs, both cystostomab govitecan and the Dato-DXd, both did improve the outcome compared to chemotherapy alone. So at least we know that the best thing to start with is the ADC. I would put that patient in the Ascent 03 and the Tropics 02 cohort. So I would go for the single agent ADC mostly. That's more even driven if the patient didn't tolerate well her adjuvant pembro. If she's okay with that, and if she's still PD-L1 positive, because we could recheck the PD-L1. Usually, you have a good chance of having a negative disease in the later biopsies. Again, I would give the antibody drug conjugate plus or minus pembro if according to the PD-L1 and according to her tolerance to the first line to the neoadjuvant. TDXD, I'm not sure, and I'm also not sure about the better CNS coverage, because the CNS, all the CNS data of TDXD came out from the HER2 positive patients, and by now we might be very well sure that the best thing to use against brain metastasis is the best thing you use against the extracranial metastasis. So TDXD, by virtue of the molecule size, does not have the CNS penetrance, but by virtue of being the most active agent anywhere in the body, is the most active agent in the brain as well. So that holds still for HER2 positive patients, because we do not have enough evidence that this holds still for the triple negative cohort. We have that Destiny Breast 06 data. That's very early again in the first line, but that's in the ER positive patients. So because we don't have enough to support the use in the triple negative breast cancer so far, I would be more inclined to use the agents that have proven survival improvement in the first line. So that's cystostomab or Dato-DXd, one of the two agents.
I think there was trial, DEBRA trial, specifically in HER2-low metastatic breast cancer with brain metastasis, and the trastuzumab deruxtecan showed overall response rate of 50%, strong data, progression-free survival 10 months. while sacituzumab govitecan in active brain metastasis or even stable show less robust data. So what do you think about that, Dr. Lai?
Well, sure, it is active. That we're sure of that, but we cannot be sure that it is more active than an agent that's already have proven overall survival in the first line setting. So maybe we're here talking. Most probably, this patient will receive both the anti-TROP2 and the anti-HER2. So the question is, which one first? So while I do have the data to support the first line TROP2 inhibitors so far, and do not have the HER2 till now, so that's why I would consider giving that sequence even in a brain metastasis situation. Usually those patients who do relapse with not like the HER2 positive patients, they do relapse with a predominantly extracranial disease, but in addition you might have a brain metastasis. That's very different from the HER2 positive disease, which brain relapse might be much earlier than the extracranial disease, and you have to go on treating first line, second line for brain metastasis only disease. So that's why I'm considering the systemic therapy, irrespective of having brain metastasis or not, a little bit different from what we consider in the HER2 positive disease. But again, we do not have enough evidence to support the comparison. That's the point. So DXD first isn't wrong, and again supported by the idea of if the patient had brain metastasis, that would be okay. Again, to me also, if I don't have access to the ADCs, which is the case for everyone in the world in the first line. So I would go for the Keynote 355 regimen, which contains platinum. So if she did relapse, 18 months after receiving the last olaparib, then she did relapse like 3 years after receiving the last carboplatin. So I would use the Pembro plus Gem Carbo. That's expected to be an effective treatment in the BRCA positive patient. So I would try that in the majority of patients because we don't have access to ADCs in such situation. It's not approved yet.
Is there, Dr. Luay, is there any way to re-administer PARP inhibitors again? Or it just should be given once and that's it?
There are some data from ovarian cancer where you can redo, but again, for the first line setting, in the PD-L1 positive disease, we do have a treatment that did improve the overall survival. That's the Pembro plus chemo. The olaparib failed, and the talazoparib also, they failed to improve the overall survival in the Olympiad and the BRCA studies. So again, they can induce good responses, but it's short-lived usually. So that's why I
consider it as a later line. If there is, we don't have so much to give anymore.
If you didn't develop platinum resistance very early, because that's the problem. But again, if you know what would I do in that patient, what would I do is usually not supported by the guidelines because I would do like I do in ovarian cancer patients. I would start with the Gem Carbo for induction, in addition to Pembro or no Pembro, according to the access. Then I will follow by maintenance olaparib, and I will not wait till disease progression to redo olaparib, just like the Olympiad and the BRCA. In such two studies, it was not allowed to use the treatment for maintenance. But in the ovarian cancer patients, that's the usual use of PARP inhibitors, and that's the most successful use of PARP inhibitors, actually, where it did manage to improve the survival in platinum-sensitive disease. So I would do that. I would give the platinum combo at the induction, followed by a maintenance olaparib or talazoparib, whatever we have access to. I think that with that approach, if the patient responded to the first line platinum, that you would have better long-term disease control compared to the wait and redo PARP inhibitor.
This case also raises a couple of questions. First, about the role of prophylactic contralateral mastectomy in cases who already developed breast cancer. Do you think this is like a common practice that we should encourage?
Equivalent to just surveillance, but the recurrence rate were lower, but the overall survival is the same. So prophylactic contralateral mastectomy is acceptable, but not mandatory. Not mandatory in BRCA1 mutation.
And then why don't we do bilateral oophorectomy as well if we go on this way?
Yes, there is specific criteria. I think after 40 years old or completing her family, we can go for bilateral subungual oophorectomy, of course.
Okay. There's also another question.
While I discuss with my patient, that's a very important point to discuss the prophylactic surgeries in BRCA positive patients. In patients who are at high risk to have disease recurrence. That's a very tricky situation. I wouldn't have gone into the same pathway with doing the surgery, the concomitant surgery of the two breasts, because if I found my patient to have a residual tumor in addition to residual positive lymph nodes, then the scenario where that patients went through of an early recurrence is not uncommon. That's very common. So I would give that a chance of 50%. So if the patient did have access to that piece of information, that she is expected to have a metastasis by an incidence of around 40 to 50%, then she might not have opted for the prophylactic mastectomy. It carries an additional pain and an additional scar, longer duration till recovery. So this decision is actually dependent on the pathological CR status. And while that information will not be available till after the first surgery, so I usually advise the patient to wait till we see the pathology of the surgery. Then we sit down again and take the decision. And please note that, as Dr. Manar have mentioned, the prophylactic oophorectomy did provide better mortality reduction. Yeah, better mortality reduction than the contralateral mastectomy did. So I would advise to plan everything. Well, for example, if the patient is 45 years old, I would go for the prophylactic oophorectomy first, or at least earlier. Then I would discuss the prophylactic mastectomy. In addition, we might need radiation therapy to the ipsilateral breast, and hence a little bit change in the residual flap size and the consistency. So the symmetrization of the reconstruction process from the surgical point of view might need to have a revision if you did the surgery earlier. Of course, it will be 2 surgeries or even 3 surgeries, but each one would be much more informed when you go through that decision. So I would wait till I see the pathology report and know the residual disease status before I discuss the risk reduction surgeries. Again, many patients would like to take away the other breast at the same time at the same surgery.
Okay. Regarding our patient, she has pulmonary nodules, not extensive, but what if it was very extensive lymphangitis carcinomatosis? Would you go for trastuzumab deruxtecan or shy away to sacituzumab govitecan, given the risk of ILD with trastuzumab deruxtecan? Because she is symptomatic, she has cough, she has dyspnea, and we now planning to start trastuzumab deruxtecan. What if she developed ILD during treatment? You can differentiate, is this from tumor or this side effect from treatment? And as we know, grade 2 ILD requires permanent discontinuation of trastuzumab deruxtecan. What do you think, Dr. Lai?
Well, Dr. Manar was one who's going to start the TXD upfront, but again, I would, even if we're in the second or third line and we've considered to start TDXD, having lymphangitis is not, for example, if that's a HER2 positive disease where I put a much higher hope on the use of TDXD to alter the course of the disease, I would not shy away from using the more effective treatment because it's of the lymphangitis carcinoma. Actually, it's even less tricky to during the symptom monitoring, especially in HER2 positive disease when you usually find earlier responses. So the patient gets better. Then again, that's even if you have some little bit changes in the CT scan that you're not sure about it, then she's getting better. This means that's all of the disease and it's getting better. And if the patient gets worse, then again, it doesn't matter what's the cause of her getting worse. If she's disease is progressing, or if the dyspnea is getting worse because of the toxicity from the TDXD, or probably will stop the treatment anyway. But again, one other point that's not usually the guidelines is confused about it is whether you use prophylactic steroids for those patients or not. If I expect a good risk-benefit ratio from adding steroids, I would preferably use a prophylactic steroid to that patient. It will improve. It might improve the symptoms of the dyspnea from the malignancy a little bit, but I think it might help even with preventing the ILD, or at least reducing the magnitude of the problem. I know that that's we have ongoing studies to test that point, but I would use it in such a very peculiar patient with a visceral crisis. I would use the prophylactic steroid if I was going to use the TDXD.
And also, so what's your schedule for screening for ILD in general, not this patient? Do you follow a specific schedule every 2 months, every 3 months? And what imaging do you recommend? CT with contrast, CT without contrast?
I do CT without contrast, and we usually do the assessments, the tumor assessment every 3 months. So that's every 12 weeks, and we do usually by PET-CT or CT with contrast according to the access. But in general, we have good access to PET-CT in Egypt, so we use it frequently. But the point is that the PET-CT usually fuse with the low dose CT, and that's not good to check for the ILD. So usually I write in the requesting for PET-CT, I instruct the radiologist to do a high resolution CT scan film in addition to the PET-CT, and that's an additional like 1 minute time to the PET-CT test. So here we have one CT scan every 12 weeks. I would do one in the middle, 6 weeks after starting the medication, so that I will do every 6 weeks one high resolution CT scan, non-contrast, of course. We don't need it to check for the ILD, the contrast matter, and most patients find it easy to do. It's a 1 minute test, so it's easy to have it, and it's not very expensive as well. I do recommend that at least in the first 6 months, and after that we might reduce the assessment to once every 3 months. Usually, most of the ILDs they happen in the first 6 months.
Okay, understood. Regarding the brain metastasis question, does this patient needs baseline MRI brain, even if asymptomatic, or no need? Because she is triple negative, which put her at 20, 25, 35 risk of developing brain metastasis over her disease course, and the BRCA1 also strong prognostic for brain metastasis.
I would do that. I would do the screening, but most of the oncologists will not do that. I will do it usually. It's not endorsed by the guidelines. So if you practice within a full guideline system, then you'll not be able to do it easily. But if I have access to do whatever I want, I would screen those patients. Not because she's brain metastasis, not because she's triple negative, but because she has a BRCA mutation, and because she's having lung metastasis. We have done a huge retrospective study on the predictors of having brain metastasis in patients with breast cancer, metastatic and early, and we did provide like a model of independent risk factors that predict the risk of having brain metastasis. HER2 positive, of course, is top of the list, but the triple negative breast cancer per se might not be predictive of having more brain metastasis, except if it was BRCA mutant. So we believe that, at least from our cohort and other similar cohorts, that the risk of developing brain metastasis in triple negative breast cancer is driven, and then ER positive as well, is driven by the BRCA-like phenotype, where they have a really high, might be even close to the HER2 positive disease. So that the second independent factor was, in addition to the genotype, was the presence of lung metastasis per se. And lung metastasis, there is a biological rationale behind it, but patients who develop lung metastasis are more commonly to develop brain metastasis. So that's why I would screen patients for brain metastasis at baseline. Those patients with HER2 positive disease or with BRCA mutant disease, I'll screen them for brain metastasis. I could even monitor by MRI in subsequent, every 6 months to 12 months. I might look for asymptomatic brain metastasis and treat them early with like stereotactic radiation if you found them. So again, that's a step that's not endorsed usually by the guidelines, but I think that in the future you might find some recommendations in the same score.
Very good.
Yeah, like it is not in the guidelines, but I was at MD Anderson last month, and they do it for every patient. So whatever cancer, it's like it's part of a staging. Even patient come from other institution, they didn't get an MRI brain, they do it, even if asymptomatic.
The question, will it change the management if we detect the brain metastasis earlier? Will it make any difference in prognosis or line of therapy?
Because sometimes they use local therapy. If the patient has like solitary brain mets, they send them for radiation therapy, gamma knife. So if any patient have lymph node metastasis, they usually do MRI brain.
Even early stage.
Yeah, it's a part of initial screening, initial staging.
Okay. طب
It
regarding
doesn't
the
have to be an MRI brain. If the patient have a CT head, they usually accept it. But if he doesn't have any, they usually order MRI brain. MRI brain.
It should just be noted when you're discussing this with the patient, because the MRI is not an easy test to request from the patient's perspective, that you probably do the MRI and have a negative test in the majority of patients. So even in the patients that I'm talking about, where, for example, HER2 positive disease and lung metastasis, the risk of having brain metastasis at the first diagnosis of metastatic disease, like your patient, it's probably below 15%. So that's a rare event, and the risk of having at a lifetime by the first line, second line, third line, and all that would be around 40 to 50%. So that's why in the first line it's not a common event, and in the early disease it's less than 5%. So if you're going to do a brain MRI, it's a 95% chance or more that it's going to be negative. So that's the point when discussing with the patient. You do not need it, just like in late line breast cancer, where the risk is higher.
I have another question. Our patient received the adjuvant Bembro. She didn't develop pneumonitis, but what if she developed pneumonitis and resolved on corticosteroid, and now relapsed, and we are comparing trastuzumab deruxtecan with sacituzumab govitecan? Would you choose trastuzumab given her recent pneumonitis, immune-related adverse events, or you will go for sacituzumab govitecan? Pneumonitis from immunotherapy. Resolve it with steroids. Should we go with trastuzumab deruxtecan given the risk of ILD?
I would go if I need it very much, but to me, I would go for the third option. Actually, if I have all the options, that's Dato-DXd in that situation, or the first line, for example. But I think if your question is about the second line and beyond treatment, where you do have to choose between both, again, to choose which comes first. I would consider I would not find that a problem to restart TDXD if I have the same stoppage guidelines thing. If it's like a grade 1 and you did stop and it resolved, then you could re-challenge, even if that was a TDXD induced pneumonitis. If it's a high grade with any residual grade, if it was a high grade or life-threatening condition, then I would not restart TDXD. I would delay it or even omit it. So I would consider that as if she had a TDXD induced pneumonitis. Again, they're not the same, and the mechanism might be a little bit different, yet there is an immune component used in that. and I would try to avoid having pneumonitis. But if it fits the guidelines of restarting TDXD, it's a grade 1, for example, and it did resolve within, for example, 1 month, then I would consider I would consider using TDXD, just like I would consider reusing TDXD if that patient developed TDXD related pneumonitis.
Okay, since we are talking about adjuvant pembrolizumab, this patient, like a lot of patients we meet that don't achieve pathological complete response after new adjuvant pembrolizumab. Do you think it is effective economically, looking from the economic perspective and also from the survival benefit, to continue adjuvant pembrolizumab if the patient didn't achieve PCR?
The short answer is no. It's not from the economic point of view. If you look into like a cost-effective implication of continuing trastuzumab, continuing pembrolizumab, or switching to olaparib, then you probably find the most cost-effective measure is to switch to olaparib. That question was implicated in the Egyptian guidelines, and because it takes the cost effectiveness component into the implementation of the guideline. So it's different from the NCCN guidelines, for example, and it's more closer to the NICE guidelines in that scope. And again, it's not included the continuation of pembrolizumab beyond PCR, or the combination of pembrolizumab plus olaparib, just like your patient here continued. It's not endorsed by the guidelines, or not endorsed most probably by any cost effectiveness minded guidelines. So from the cost perspective, I would not recommend that.
It's not a small number for patients who achieve PCR. 65% of the patients in this trial, Keynote 522, who achieved PCR. So this question is very important. So we are treating a lot of patients without concrete evidence. I think there is trial ongoing right now discussing this issue.
Yes, the optimized study still ongoing, and
optimize, yes.
But here the optimize is within the optimized PCR component, which is mostly the most needed question is what to do in those who achieved PCR. Do we need to continue the next 6 months on pembro or not? But here the question is probably for the patients who did not achieve PCR, whether to stop the pembro and start the additional chemo, which is so far the component, the capecitabine or olaparib, capecitabine if BRCA negative, and olaparib if BRCA positive, just like this patient, or you continue the 6 months of pembro in addition to whichever medication you use. So that's the more difficult question to design a trial to answer.
Last question from the start in 2023. This patient was T2N1, stage 2B. Did she need staging PET scan at baseline? Guideline versus practice. In practice,
it depends on whether you'd like to see more metastases or not. So if you do more PET scan, you'll have a chance of having more upstaging, and if you don't, you would have. Sometimes we like to see more metastases. Sometimes we don't like to see more metastases. But again, it's I wouldn't insist on having PET-CT if that's your question.
Because in NCCN and ESMO guideline, stage 1-2 breast cancer, no need for baseline staging CT plus bone scan or PET scan. If she is stage 1-2, no need, not even chest X-ray or ultrasound, no need. Just to proceed to neoadjuvant or surgery. If it's stage 1, stage 2, this is NCCN guideline.
Yes, because
staging for CT or PET scan for stage 3 or suspected metastasis disease.
Yeah, because in stage 1 or 2, even if you do a PET-CT, then that's the most sensitive test. The chance of having positive true metastasis is less than 5%. So you'll end up doing PET-CT for 95 patients to find like 5 additional metastases, where some of them even can be detected by conventional imaging. So, it depends. Sometimes when you're not sure if your patient is fit for the whole neoadjuvant chemo, all that, and you want to look if she has any other disease elsewhere, you can de-escalate the treatment. And sometimes with metastatic disease that are frail patients. But in general, I would agree with the NCCN guidelines on that, on avoiding an extra screening for those patients.
That's all. I think our time is up. Any question from the audience? Dr. Manar?
That was a very informative discussion. Thank you so much, Dr. Luay, Dr. Alfie.
Thank you very much.
Yeah, nice
Yes.
presentation. Thank you, Dr. Alfie. Thank you so much, Dr. Kazem, for joining us.
Thank you, Dr. Alfie.
Thank you. Thank you.
Very pleasant. Thank you. See you.
Okay, see you next meeting, inshallah.
Inshallah.
إن شاء الله.